Welcome to the Explainer. Look, if you're prepping for your upcoming nursing exams, you already know sensory disorders can feel, well, a bit overwhelming. But here's the really great news. Mastering just 20 high-yield key points is going to make eye and vision disorders highly predictable and completely manageable on the ATI and NCLEX. So today, we're breaking down the absolute essentials of Chapter 59 into a structured visual guide that's literally going to lock this info into your long-term memory. Ready? Let's get into it. Okay, let's dive into this and map out our 20 points across 5 distinct sections. We'll hit general eye care essentials, cataracts and surgical care, glaucoma management and pharmacology, retinal detachment and emergencies, and finally, we'll put it all together by conquering actual NCLEX-style questions. Starting off with Section 1, General Eye Care Essentials. Right off the bat, let's hit key points 1 and 2, which are all about errors of refraction. Notice how in a normal eye, light rays focus perfectly right on the retina. It's seamless. But in myopia, nearsightedness, the lens is actually situated too far from the retina, so those light rays converge in front of it. And to correct this, we use biconcave lenses. On the flip side, we've got hyperopia, or farsightedness. Here, the lens is way too close to the retina, causing the light rays to converge behind it, and that requires biconvex lenses to fix. Now, the NCLEX absolutely loves testing your understanding of these specific mechanical differences and their corrective lenses, so definitely burn this concept into your mind. Moving on to key point 3, we're looking at ocular prostheses. This brilliantly illustrates a super common, highly testable nursing procedure you'll probably encounter in clinicals. If a patient has had an enucleation, meaning the removal of the eyeball, they'll likely have a prosthesis. Now, to safely remove it, you do not pry from the top. No way. Instead, you gently depress and pull the lower lid down, letting the prosthesis just slip out over the lower lid. Then, you just wash it under running water to clear off any debris. It's a really simple mechanical action, sure, but knowing exactly which lid to manipulate, that's a classic safety and hygiene question they love to throw at you. Okay, moving right along to Section 2, Cataracts and Surgical Care. Let's cover key point 4. First up, what exactly is a cataract? Basically, it's an opaque, cloudy lens that causes blurred vision and a lot of glare. Over time, the lens sheds cells that get compressed into the center, and it just loses its transparency. When we look at the surgical mechanics, the go-to procedure is an extracapsular cataract extraction. The surgeon makes a tiny incision, extracts the cloudy lens, usually using sound waves to break it up, and deliberately leaves the posterior capsule intact. Then they implant a clear, artificial intraocular lens right behind the iris. It is an amazingly precise, fast, outpatient surgery. But, the real focus for us as nurses kicks in after the surgery. Key points 5, 6, and 7 all revolve around one incredibly vital goal: preventing intraocular pressure, or IOP, spikes. So the crucial point is we absolutely must instruct the patient to avoid bending forward and to never lift anything over 5 pounds. Why? Well, bearing down or straining increases pressure in the eye, which seriously threatens those delicate fresh sutures. This is exactly why we immediately administer ordered antiemetics if the patient feels even a little nauseous. Vomiting causes a massive, dangerous spike in IOP. We also give stool softeners to make sure there's no straining during bowel movements. Now pay super close attention here because key point 8 comes with a major NCLEX alert. A mild analgesic like acetaminophen is totally fine for the typical scratchy discomfort you'd expect after cataract surgery. However, if a patient reports severe pain in the operative eye, that is a medical emergency. Severe pain is not normal. It strongly points to a hemorrhage or a dangerously rising intraocular pressure, and you have to notify the surgeon immediately. Do not just document it and walk away. You've got to act on it. All right, let's transition to Section 3, Glaucoma Management and Pharmacology. We really need to contrast key points 9 and 10 to make the two main types of glaucoma crystal clear for you. Open-angle glaucoma is the most common one. It's chronic, it's painless, and it slowly, almost sneakily, steals the patient's peripheral vision first, which creates this tunnel vision effect. The elevated pressure happens really gradually over time. Angle closure glaucoma, on the other hand, that is an acute, incredibly painful medical emergency. The flow of aqueous humor is suddenly blocked, causing a rapid, terrifying rise in pressure. Patients are going to have sudden blurred vision, they'll see halos around lights, experience nausea, and have severe pain. Acute angle closure demands immediate medical intervention. To actually manage these pressures, we rely heavily on pharmacology for key points 11, 12, and 13. And notice just how specific these nursing interventions need to be. First up, beta-adrenergic blockers like timolol. These decrease aqueous formation. But systemic absorption can actually cause bronchospasms, so you must assess your patient for wheezing. They are strictly contraindicated for patients with asthma. Next, we have cholinergic agonists like pilocarpine. These constrict the pupil to help the fluid flow out. But a big side effect is poor vision in dim light, so patient safety becomes a massive priority there. Finally, prostaglandin analogs like latanoprost. A super highly tested side effect here is that they can cause permanent darkening of the iris. We're talking turning green or blue eyes to brown. You absolutely have to warn the patient about this harmless but completely permanent change. And that brings us to key point 14. Honestly, I cannot emphasize this enough. Patients with glaucoma must avoid non-prescription cold and allergy remedies that contain drugs that dilate the pupil. Never, ever give mydriatics, which are the drugs that dilate the pupil, to these patients, especially those with angle closure glaucoma. Think about it. Dilating the pupil bunches up the iris, which completely blocks the outflow of fluid and dangerously spikes that intraocular pressure. Let's move to and see how this builds into key point 15 on patient teaching. Because open-angle glaucoma is usually painless, patients often don't actually feel sick. And you know what that leads to? A huge problem with medication noncompliance. As a nurse, you have got to stress the absolute non-negotiable necessity of lifelong adherence to their prescribed eye drops. If they stop taking them, the pressure just builds silently, and they will suffer permanent blindness. Also, make sure they know to wear a medical alert tag and always pack spare medication when they're traveling. Next up is Section 4. Retinal detachment and emergencies. So key points 16 and 17 map out the pathology and the classic symptoms of retinal detachment. It's essentially a separation of the sensory layer of the eyeball from the pigmented layer, which suddenly deprives those sensory layers of their blood supply. The symptoms here are incredibly testable. Interestingly, patients usually don't report any pain. Instead, they'll say they are seeing sudden flashes of light, a huge burst of floaters, or they'll describe the sensation of a dark curtain coming down over their field of vision, which creates a completely blacked out arc in their sight. The second a patient describes that curtain effect, you need to immediately suspect retinal detachment. Key point 18 focuses on our nursing interventions for this scary emergency. Before corrective surgery even happens, you place the patient on strict bed rest with the head elevated to prevent any further detachment. Then, post-operatively, positioning is incredibly specific. Depending on the surgical repair, especially if the surgeon injected an air bubble or saline to hold the retina in place against the back of the eye, the patient might require a strict face-down position. Because the air bubble rises to the top, positioning is dictated exactly by where the tear actually was. You've got to follow the surgeon's orders precisely to ensure that retina heals the right way. And finally, Section 5, Conquering the NCLX Questions. Let's look at key point 19 through a direct NCLEX style question. So imagine a patient comes to the clinic complaining of severe eye pain. The physician diagnoses acute angle closure glaucoma. The nurse understands that the most serious complication of angle closure glaucoma is what? Think back to that rapid pressure spike we just talked about. What's the worst case scenario? The answer, of course, is permanent blindness. And this reminds us exactly why rapid medical intervention matters so much. A sudden block of aqueous humor outflow creates a massive pressure wave that damages the optic nerve incredibly fast. We aren't just managing pain here, we are literally racing to preserve their sight. Finally, we arrive at key point 20. Here is a next-generation NCLEX matrix question that evaluates a patient's post-cataract discharge teaching. We have to figure out if specific actions are indicated, contraindicated, or totally non-essential for a 72-year-old woman heading home after getting a left eye lens replacement. Now, what's really interesting about this setup is how it directly tests our understanding of intraocular pressure. So, arrange for someone to drive you home? That's clearly indicated. Take a stool softener? Also indicated, because it safely prevents straining. Avoid bending forward? Absolutely indicated. On the flip side, what is strictly contraindicated? Lifting anything more than 5 pounds. And what's just non-essential? Eating a high-protein diet. Sure, it won't hurt, but it has no specific bearing on post-op eye healing compared to those critical IOP restrictions. And that brings us to the end of today's explainer. Vision is arguably our most heavily relied upon sense. Whether you're holding a beta blocker because your patient has asthma, or you're teaching a newly diagnosed glaucoma patient the absolute vital importance of their daily drops, or you're just keeping a post-op cataract patient from lifting a heavy box, your clinical judgment directly preserves their sight. It's a big deal. So I'll leave you with this.
How will the critical thinking you develop today preserve a patient's independence tomorrow? Keep that in the back of your mind as you study, and you're absolutely going to crush your exams. Keep up the great work, and I'll catch you next time.